Welcome to another edition of Odyssey House Journals. I'm Randall Carlisle. My usual cohort, Trip Mitchell, is not here today, and I'll tell you why. We decided to fire him and hire a good-looking lady because it could increase ratings. No, Trip is dealing with some health issues in his family. They're not serious, and so Trip is off today. And I have with me today, I think I can honestly call you a rock star doctor. Does that embarrass you?
Well, kind of.
Oh, yeah.
It's a little bit intimidating.
The reason I say this is Dr. Paula Cook is probably extremely well known in the recovery community here in Utah because she has done so much work in that area. And so we're really honored to have her as a guest today on a program that we talk about addiction and recovery and everything in between, which is a wide area. Dr. Cook it was easier to get her because she now is our medical director at our Martindale clinic at Odyssey House. And so, well, we're so happy and so proud to have a rock star doctor on board. The reason I say that is I know so many people in the recovery community, and I told them that you were going to be on the podcast, and they said, "Oh, I know Paula. I love Paula. Paula is great. Paula does this. Paula does that." And I realize it's sort of embarrassing to have people say you're a rock star doctor, but you specialize in addiction medicine, and most people know you for what you did at the University of Utah's Neuropsychiatric Institute. And can you sort of describe the program you started and why so many people in recovery know you?
Sure, Randall. I've been doing addiction medicine for quite a few years in different settings. Most recently, I've been up at uni, so the University of Utah Neuropsychiatric Institute, working in a couple of areas, but primarily with the detox program. So folks who need to come off of alcohol or drugs and make that transition to then being able to go to treatment or to get back to their lives in some way. We've been able to help them do that. So it was an inpatient facility, and I was one of the doctors that provided care there, and it was a great opportunity to learn how to do that and do it compassionately and well, I hope. And as part of that appointment at the university, I also had the opportunity to help start an addiction medicine fellowship, which entailed encouraging trainees who are finishing their residency in whatever field of medicine they've chosen, whether it's family medicine, obstetrics, internal medicine, to then choose addiction medicine as their focus and enter a one-year specialty training program. And with my mentor, Dr. Beth Howell, we were able to start a fellowship and get that going at the University of Utah, which was really fun.
So there's going to be a lot more of you around.
Exactly.
Future.
And that's the goal, is to have more specialty trained, board certified docs in addiction medicine to provide full scope care for people who are struggling with addiction and working on their recovery.
Before we get into what addiction medicine is, why did you decide to focus on this? I'm sure, I work at Odyssey House. You work at Odyssey House now. You could make a lot more as a neurosurgeon or an OBGYN or something like that. What led you in this direction?
Well, it's kind of a circuitous story, but basically I had an amazing teacher at the University of Utah as an undergrad who taught a class in drugs, alcohol, and violence. And it just captivated my interest as a social issue. And, we all have family members who struggle with addiction in some way, so it really rang a bell. From there, I got really interested in harm reduction work on lower campus with binge drinking and reducing high-risk sexual behavior. But what really made me invest in addiction medicine was when I was a medical student, and I went to volunteer at the 4th Street Clinic, which is a local, clinic for homeless patients. And the very first patient I saw, and I think I was either a first or a second-year medical student, and it's a very exciting experience for medical students because it's the first time you really get to see patients.
In reality.
Exactly.
Yeah.
Up until then, you've just been sitting in a classroom. The very first patient I saw was a lady who was muscling heroin, and she was covered in abscesses. She just had them pretty much all over her thighs and her upper arms. And she was suffering so much. And I was talking to her and getting her story and what was going on. And she obviously had unstable housing. She was trying to live from one access to heroin to another. And she had all these terrible skin infections. And I just couldn't quite believe that someone with this much affliction wasn't a higher priority in our medical system. It kind of just reminded me of someone with leprosy. Like, how can we not care about this person so much?
Yeah.
And she's literally lost everything because of this condition, this addiction that she had, to the point where she had nowhere to live, no family, and her body was literally so infected. And I just was like, that's it. And that's kind of the person I am.
That's what you want to do.
I was like, this is an issue. This is a problem. We've got to do something about this. And obviously, I'm not going to solve the problem, but I really felt drawn to it. And I was able to then engage in more and more really interesting and rewarding and, humbling experiences where I was able to work with people with addiction and see how they can get better. And I just love it. I love it more and more.
Which is... people watching who don't understand addiction must say you must be a glutton for punishment, because it is depressing to see situations like that. One of the big changes I've noticed, first of all, you mentioned the word harm reduction, okay, and that's just a concept that is becoming more generally wide known right now. Describe what harm reduction is in real terms. Like, okay, I'm a heroin addict, and if I get my fix every day, I'm sort of okay. What is harm reduction in terms of you dealing with me? What would you say?
Well, harm reduction in the general term is an approach to meeting people where they are. And so instead of saying, I'm the medical system, I'm the authority on this issue, on your issue, you need to be this way, which is typically sober, doing 90 meetings in 90 days, finishing treatment, etc. It's saying, well, what do you need right now in your path of addiction to keep you with a better quality of life, whether that is having access to housing, having access to food, having access to safety, not having your very safety be at risk, and having access to the kinds of things that keep you safe from infectious disease. That's the general concept. Until you may be ready to have a different life and access treatment or gain sobriety through whatever way you can. That's the general concept of harm reduction.
So basically, you're saying it's okay for me to continue as a heroin addict, but you want to make it as safe as possible while I continue on that path.
Right, if that's what you want to do, because not everybody is ready to quit. They may have reasons why they're not quite ready, or maybe they're ready on some days and not the other. They have some ambivalence. People are using for a reason. They got into addiction for a lot of complex reasons, and it's very difficult to quit, right? If it was easy, it wouldn't be a problem. People would just quit.
No, that's true. Okay,
Yeah.
I won't do it anymore.
Exactly.
And that's what the outside world sort of thinks, too, when they look at a heroin addict or an alcoholic, just stop.
Exactly,
Yeah.
and it's not that easy. So harm reduction tries to reduce, this medical word is to reduce morbidity and mortality surrounding drug and alcohol use. So while you are using, let's see what we can do to not have some of the harms associated with using, whether that's infections or falls or loss of your family, whatever it is. We want to try and help surround you so that you keep as healthy as possible until something may change for you. And we're there for you when that process happens.
How do you, as a doctor, though, deal with that? Are we talking about clean needles, wound packs for all the abscesses? How do you deal with that specifically?
Yes, well, it looks a lot of ways. Definitely providing access to clean needles for people who inject drugs and clean cooking kits. Providing access to overdose kits, so naloxone for people who use opioids. And it goes beyond that. So for people who drink alcohol, who are not ready to stop, I like to have conversations about how can we keep you safe while you're drinking. Let's make sure that you're not at risk for falling. Let's make sure you're not on medications that are going to worsen your liver while you are drinking. Let's make sure you're not driving while you're drinking. Those are all harm reduction things. And, we all do harm reduction things all the time. We put on a seatbelt. That's harm reduction.
Right.
So it's just a way of looking at folks and saying, this is how we're going to minimize the damage that these drugs and alcohol are doing for you. So, yeah, that's what we try and do. Medications can help reduce some
I want to get into
craving.
that in a minute,
Okay.
but what I'm observing is that you're removing the stigma or the judgment on me as a heroin addict or me as an alcoholic, and you're just treating me as a person.
Well, sure, that's the goal always, is to meet people as the humans they are and to just offer them. It's not black and white. It's not saying, well, until you're ready, then we're not interested in you. Because that's kind of been the model, I think.
Sure it has.
And that doesn't work, right? Because then people are stigmatized and ostracized from the medical system, which may be helpful for them. Instead, we want to say, look, how can we work with you? Whenever you're ready, we're here to help you. And there's lots of areas that we can do that we're far away from in this country. Other countries are doing things like safe injection sites and even making sure that people have access to clean drugs. And I don't mean clean as in you're clean and sober. I mean the actual drug that people are using is not contaminated.
So that they're not laced with deadly fentanyl or something like that.
Exactly. So there are things that we're doing in the harm reduction arena that are good, and I think we have a long way to go.
How do you sell that to a person who doesn't understand that addiction is a disease and it's complicated and it's really difficult to overcome? How do you sell that to somebody who's not familiar at all with addiction and thinks, what, you're just in, because I've heard a lot of people say, if you give them needles, clean needles, or if the debate comes up over safe injection sites, you're encouraging drug use.
Yeah, that's a complicated question. And I think when you look at the evidence and you look at the research and the science behind what happens when we offer these services, you find that these things are not true. So instead of saying, oh, well, by giving you clean needles and by providing clean, safe, supervised places to use your drugs, we're encouraging you to use drugs, that doesn't actually happen. What happens is we interface with populations and people who are using drugs in a loving, supportive, non-judgmental way, and we provide them with access to other services once they gain trust in those harm reduction services. So you keep saying, anytime that you're ready, maybe you want to come into treatment, or maybe you want your hepatitis C treated, or maybe we can do something about that PTSD that's driving your drug use. And because they trust you and know that you don't have that judgmental, authoritative tone, they might want to enter treatment. And we see that from the research. And in the meantime, people are not dying from their disease.
Which is important.
Right, as much. I mean, they still are, but it is important. I mean, we care very much about people who have life-threatening diseases like heart disease or cancer. We do everything we can to prevent them from dying from that end, and yet when people have addiction, we tend to just say, oh, well, that's your fault. Come back when you're ready. And we don't do that to a cancer patient. We don't say, well, come back when your cancer's gone. Good luck with that.
Yeah, you're right. And anecdotally, I've seen, because I've been at needle exchanges and in a place like Pioneer Park or something, and one of the really cool things about that is representing Odyssey House or any other treatment facility, we hand out information if the people there to get clean needles are interested in treatment. And it's not like, hey, you got to go get treatment. It's just, are you interested in this? And the thing I've noticed is that you're meeting people where they are, which is a lot different than, say, arresting somebody and saying you got to do this or right. That kind of stuff, or in an emergency room saying you've got to come clean or something. It's just a nice way to meet them. I want to talk about, we're going to take a quick break, about medication-assisted treatment, which I still, just like harm reduction, I find very controversial in the outside world, and by outside world I mean people who are not associated with recovery or addiction. So the number, this is not a program designed to get people into Odyssey House. It's just that I work at Odyssey, and we thought a good title would be Odyssey House Journals. If you want any information on treatment, and not necessarily at Odyssey, but any questions you may have about addiction or anything like that, it's 801-322-3222. So give them a call, and if you have any questions about a loved one who you're concerned about or anything like that, and we're not going to steer you to Odyssey House treatment, but if you have questions, please call that number. We'll be right back after this. Welcome back to Odyssey House Journals. My guest today, Trip Mitchell, my co-host, is off today because he's dealing with some health issues with his family, and he will be back for our next podcast. My guest today is that's terrible to forget, Dr. Paula Cook. It's one of those things that happens as you grow to be my age, I guess. Anyway, Paula Cook is medical director at Odyssey House Martindale Clinic, and she specializes in addiction medicine. And we were talking about harm reduction, and we want to get into medication-assisted treatment. Sorry, I forgot your name there.
That's okay.
I've known you for a while. Describe what medication-assisted treatment is. And I think that's almost as controversial as the concept of harm reduction, because you're talking about continuing to give somebody a substance that may keep them sort of equalized, but still could be an addictive substance. So,
well, I mean, I have a lot to say about that.
Okay.
I would disagree with you. Medication-assisted treatment, we're actually moving away from that term. So we're moving towards medications for addiction treatment. So you might see that in the future. It's still, the acronym is still MAT.
Everybody says, Matt, where are you going to, if you add the F,
Yeah, we have to drop the
that's
F.
hard to say.
Because we figure that, there's medication-assisted treatment for diabetes and for hypertension.
For everything.
Exactly. So we shouldn't have a specific acronym just for addiction medications. Again, this puts it in this different category where we feel like folks with addiction have to have all the special attention when they receive medications to treat them. But actually, the history of medications to treat addiction go back into the 60s, when a German physician found out that methadone was very helpful in treating heroin addiction cravings. So it's been around for quite a while. Methadone has been very successful in terms of the hard data, in terms of reducing people dying from overdose, decreasing the criminal activity, increasing people's reentry into the job force, and also reduction of drug use. Until about 2003, methadone was pretty much the only medication that we used to treat opioid addiction. And after that time, we had the introduction of buprenorphine, which people fondly know or unfondly know as Suboxone.
Right.
And then we've had other medications come along like naltrexone. We also have medications, or MAT, for alcohol use disorder, alcoholism. And the reason why it's controversial, like you mentioned, is people think, well, maybe we're substituting one drug for another. We have someone who's using heroin or oxycodone or even maybe alcohol, and we're giving them a medication that's altering their mind still, and now they're addicted to this medication. And so how is that helping them? And maybe they're not really clean or not really sober.
Because Suboxone and methadone are opiate-based.
They are opioids. Methadone is a full opioid. It's a direct sibling to any other opioid you can abuse and get hooked on. And in fact, methadone in and of itself, some people, that's their drug of choice. Suboxone is a partial opioid, so it hits the same receptor in the brain that opioids do, like heroin or oxycodone, but not quite all the way. It's kind of like turning the dimmer switch of your lights in your living room to halfway. So it kind of helps turn the lights on so you can see, so you don't have cravings and withdrawal, but it still turns the lights on, so you still have withdrawal if you stop it suddenly. The good thing about Suboxone is for most people, it doesn't make them feel really rewarded, and it doesn't drive them to want to take it more compulsively or in an out-of-control manner, which are kind of the three characteristics of an addiction. Instead, it should stabilize brain chemistry enough so that people can focus on their recovery. So they're not always thinking, when am I going to use again? I wake up first thing in the morning, when am I going to have that first fix? What am I going to do? Am I going to have enough money? I've got to go right now. That constant thinking, that voice in your head. The goal with a medication like Suboxone and even methadone is to help quieten that down so the cravings turn way down, withdrawal's not an issue, so that you can actually get on with your life, figure out your legal issues, work on your health problems, your relationship issues, your financial problems. And the reason why it's controversial is people just don't understand that it's a medication that can actually be quite life-saving, because until you overcome the hurdle of having such deep-driven cravings, you can't do those other things.
Because people don't understand that, like, getting dope sick withdrawing from heroin or any opioid is really bad.
Oh, yeah. I mean, people who have withdrawn from opioids feel like they're going to die.
Right.
I mean, it's the
I've
worst
heard that
flu
many
you've
times.
ever had in your life, and it will drive you, even if you don't want to keep using, to continue using. And a lot of people will tell you they don't use to get high anymore. They just use to stay
Feel
not
normal.
sick.
Yeah.
Exactly.
And so these both Suboxone and methadone will keep somebody stable but not high.
Ideally. Now,
Right.
you can abuse pretty
Sure.
much anything.
Yeah.
So they're given under controlled circumstances, ideally. Methadone is only given in opioid treatment programs
Right.
that are federally regulated, and you go and you dose every day in front of a nurse, etc. Suboxone is unusual because it can be given in an outpatient setting. So you can give it in a clinic and you give people a prescription and they pick it up and they can take it home. So it has a little bit more freedom in terms of someone having the responsibility to take care of that medication and not overuse it or sell it to someone else,
Right.
etc. Which makes it a little bit more controversial. I think people are like, oh, well, what if they do this with that? What if they don't, take it correctly? The truth of the matter is Suboxone's a lot safer than heroin is, and it's a lot safer than fentanyl is. So when we get all worried about Suboxone and what it's doing to people, let's just really take a look at what heroin and fentanyl are doing to people, and it's taking people's lives every day.
Let's before we run out of time. There's one other drug that is part of medication assisted treatment,
Right.
which I took the pill form when I got sober 8 years ago.
Right.
Vivitrol.
Yes. Vivitrol is actually the brand name of the injectable version of naltrexone.
Which is, at that time I had to take pills.
The pills. And
Yeah.
we still have the pills. And naltrexone's a very old medication. And we came across it accidentally. So it's a dermatological drug originally. And it helps with itching. And when dermatologists were giving it to their patients who had itchy rashes, such patients who abused alcohol came back and said, Doc, funny thing, I don't need to drink as much. And this
Or
is
scratch
how,
as much.
Or scratch as much. So that's how naltrexone actually
I
became
did not know that.
scrutinized for an
Wow.
alcohol craving drug. And Randall, it's very effective. And we have it
I didn't know why, though. I mean,
Yeah.
my doctor said,
Take it.
Take this every day and just see if
see
it
what
helps.
happens, right?
Yeah.
It's a very unusual drug in terms of its mechanism. It blocks the opioid receptor completely, so it's
Which
not
means
like
I can't get drunk if I drink?
Well, alcohol is a very messy drug. Alcohol hits a lot of receptors in your brain and your gut. It hits serotonin, norepinephrine, dopamine, and a lot of other happy endorphins. So when you block the opioid receptor, you're really only blocking one mechanism in which alcohol gives reward to the brain. However, for some reason, naltrexone seems to be quite effective in reducing alcohol cravings and opioid cravings. So we found it to be really helpful, and it's a great medication in our toolbox. And we recommend it. I say I've had thousands of patients on Vivitrol or naltrexone tablets if they don't want to take the shot.
And
it's
Odyssey's Martindale Clinic is, I think, the biggest distributor of Vivitrol in the state, I think.
They are.
Yeah.
And I'd say they're fast going to become one of the biggest distributor of the injectable Suboxone medications, which is a new medication.
Oh, I didn't know there was.
We now
Wow.
have injectable, so buprenorphine, which is the trade name for Suboxone,
And-
now comes in an injectable version that lasts a whole month, which
You're
is
kidding. Which is what Vivitrol, we didn't mention that. Vivitrol lasts for, 28 days?
28 days.
Yeah.
I mean, I would say
Give or
give or take, and more likely under 28 days for a lot of people. So you have to work with your provider and make sure that you're catching that interval that's just right for you.
Right.
But it's a great option, and now we have this new medication called
Wow.
Sublocade that is buprenorphine injectable, and Martindale Clinic does such an amazing job. I'm so impressed.
Is it available at Martindale?
It's available at
Wow.
Martindale. Medicaid pays for it
Really?
with no prior authorization.
So you don't have to worry
Thank you
about
for
your
that.
craving or anything else for 27 days, 28
Exactly,
days.
and you don't have to worry as a provider or a clinic that you're giving a medication to someone who doesn't have a safe place to store it, who may be selling it or overusing it. So a
Wow.
lot of these legislative or community concerns about Suboxone are kind of waylaid when you think
Wow.
about Sublocade. So we're really excited about this medication. And, if Big Pharma's working on other formulations of these medications and hopefully more, because we only have 3 medications for alcohol and 3 for opioids, none for meth, none for cocaine, none for marijuana. And if you think about conditions like high blood pressure or diabetes, we have dozens and dozens of medications available. So we're behind,
You're
but we're
right.
getting there. We're getting there.
And
we're
you would
working
think
on
with
it.
the number of people that have issues with alcohol or drugs, that Big Pharma would be working on that
Oh, yeah.
full time.
I mean, 25 million people in this country. So they're working on it. But again, it's a stigmatized population and not so glamorous, but we're getting there.
Wow. We have 2 minutes left. I've got to get this in. You just took over as director of our Martindale Clinic. Describe what services are available and who Martindale serves.
Martindale Clinic is a full service primary care clinic for people with addiction or substance use disorder, whether they're in recovery, whether they have active addiction and they're not able to stop using. Doesn't matter where you are in that journey, you're welcome to come and get services there. They treat a lot of hepatitis C infection. They do preventative care such as cholesterol, high blood pressure, screening. They do women's health, they do pap smears, contraception, planning, and everything in between. So it's a really great model. They also do behavioral health management, so manage mood disorders, bipolar disorder, depression, and really want to be a medical home for people with addiction in a place that's safe, non-judgmental, and that you can always come back to pretty much your whole life.
I think the fact that the most significant thing I've noticed when I've been there is how non-judgmental it is. Mm-hmm. Because if I'm an alcoholic, which I am, or an addict or something, I'm afraid to go to somewhere and say I've got this problem. Mm-hmm. And at Martindale, it's not like you're bad. you gotta work on this.
Sure, yeah, that's the goal, is to just have this really safe place, and there's no shame, there's no stigma. It's just the way it is. We're just treating it alongside any other chronic condition, and we want to keep seeing you just like we would for any other chronic condition. You're just going to keep coming whether you're doing well or whether you're not doing well. Just keep coming on back.
And that's significant. If I came in and I said, yeah, I relapsed, what would you say if you were my doc?
Well, I'd say, okay, well, what do you want to do? What should we do? What's the plan? Let's go. You know, just as much regard for you and what you want to do and try and get you. And hopefully I'd know you by then, or if I didn't, would say, let's talk about your options and let's talk about what we can do to really support you through this. And I would like to see you every week or more often, and what services can we link you into, and let's do everything we can to try and support you so that this doesn't last very long. You can
Thank
get back
you
on your feet.
so much. We're honored to have a rock star doctor on staff at Odyssey House now, and that's wonderful. Welcome aboard. I'm glad we could do this.
Thank you.
And I wish you the best. There's going to be a lot of changes at our Martindale Clinic, and which we won't reveal now, but we will at some time in the future. So good luck and welcome aboard, and it's really nice to talk to you for a half hour.
Yeah, thanks, Randall.
Thank you.
It.
This has been Odyssey House Journals. Trip Mitchell will be back for our next podcast. And I'm Randall Carlisle, and thank you for watching.